EKG interpretation and anatomy and physiology of the sinus rhythms. We're going to talk about the layers of the heart, such as the structures of the heart and the vascular system. We have three layers of the heart, which include the epicardium, myocardium, and endocardium. The epicardium is the external layer which protects and prevents excess expansion or movement of the heart. The myocardium is the middle layer which initiates contractions, driving the cardiac cycle. The endocardium is the inner layer which lines the internal cavities and valves, and you can see in the diagram on the right the different layers of the heart. I also want to talk to you about the pericardium. The heart is enclosed in a double-walled fibroserous sac, which is called the pericardium. It's attached inferiorly to the diaphragm, laterally to the pleura of the lungs, and superiorly to the large blood vessels, like the aorta. The space between the layers contains approximately 10 to 30 mils of clear fluid, which does not clot. The pericardial cavity can actually hold up to 300 mils of fluid without interference of the cardiac function. The degree to which the pericardial fluid affects cardiac function depends more on the rate of raise in the volume than on the amount. But it will get to a point, if the fluid keeps accumulating, that it will actually cause a tamponade of that cardiac muscle, and that's when we will have a cardiac tamponade. We're going to talk about the chambers of the heart. The right and the left heart are two pumps which are paired. They both have the same filling capacity, but differing force and pressures. The right, which is the pulmonic side, is a low pressure pump which circulates blood to the lungs. The right atrium is designated as high flow, low pressure system. It receives deoxygenated blood from the venous system, specifically the superior and inferior vena cava. The outflow is through the tricuspid valve. The right ventricle pumps blood through the lungs and to the left atrium. Inflow is through the tricuspid valve, and outflow is the pulmonic valve. The left side is also called the systemic side. It's a high-pressure pump which circulates the blood into the body. The left atrium receives oxygenated blood from the lungs from 4 pulmonary veins. Outflow is a mitral or bicuspid valve. The left ventricle delivers oxygenated blood to the body, and the inflow is the mitral valve. The outflow is the aortic valve. The chamber separators are also known as the intra-atrial septum, separating the atria, which leads to the separate oxygen saturation levels. The intraventricular septum separates the ventricles to keep the pressures distinct. These septums are comprised of connective tissue, and you can see in the diagram below how the septums do separate the left and right ventricle and the left and right atrium. That's why we always on admission take blood pressures in both the left arm and the right arm of our clients, because if there is an interruption or an aneurysm in that septal or in the septums, then it could be reflective on the left or right blood pressures. We have two sets of cardiac valves. The atrioventricular valves are comprised of the tricuspid or three cusps valve located between the right atrium and the right ventricle. The mitral bicuspid, which is 2 cusps, is located between the left atrium and the left ventricle. The chordae tendineae are string-like fibers that connect valve leaflets to the papillary muscle in the ventricles. The valves will open passively during ventricular diastole. The closure of the mitral and the tricuspid valves create the S1 lub heart sound and can be auscultated at the left lower sternal border for the tricuspid valve and the cardiac apex for the mitral valve. It occurs with systole, and S1 is heard best with the diaphragm, as it is considered a high-frequency sound. The bell is used with low-frequency sounds such as S3, S4, and murmurs that are caused by mitral stenosis. We also have the semilunar valves, which are comprised of the pulmonic and the aortic. The pulmonic valve is a 3-crescent valve between the right ventricle and pulmonary artery. There is no papillary muscle or chordae tendineae connections. The aortic valve is located between the left ventricle and the aorta, originating at the coronary arteries just distal to the aortic valve. This valve is similar to the pulmonic valve with crescent-shaped cusps. The thick annulus is a ring-shaped structure at the base of the valve, and it supports the valve's leaflets, anchoring the valve to the aorta. The closure of the aortic and pulmonic valves create that S2 sound, or the dub. This sound is heard best at the pulmonic listening post or the left upper sternal border. A delay can occur between the aortic and pulmonic sounds and is called an S2 splitting. If the S2 splitting is prolonged, it can be a sign of heart disease, such as atrial septal defect or a right bundle branch block. Sometimes it's difficult to differentiate between a physiological split and a pathological split, so assessing your client's associative symptoms is necessary. This shows you our valvular action. If we have systole, which is a period of isovolumic contraction, the semilunar valves will close and the AV valves will close as well. As we move on to systole, the period of ejection, the semilunar valves will open and the AV valves will close. As we move on to diastole, which is a period of isovolumic relaxation, we will have the closure of the semilunars and the AV valves. As we move on to diastole passive ventricular filling, the semilunar valves are closed, but the AV valves are opened. As we move on to diastole, the active ventricular filling, semilunar valves will close, AV valves open, and we move back into systole, the period of isovolumic contraction. It would behoove you to spend some time with this heart diagram because it really helps you, especially if you're going to be taking care of cardiac patients, what the major vessels are, if they carry oxygenated or deoxygenated blood. It shows you the chordae tendineae on the AV valves, and as you can see, the semilunars do not have the chordae tendineae. It's easy to dissect a heart and see the chordae tendineae in separating the atrium from the ventricles, but you really have to dissect deep if you want to see the semilunars. If you look at the bottom of the page, you can see the heart valves and how they are differentiated between 3 cusps and 2 cusps. This is probably one of the best pictures that I've seen, so I wanted to include it with this presentation. Coronary circulation, it really helps you as you are taking care of a patient who is suffering from a myocardial infarction, because knowing the different vessels that are affected due to the circulation will help you understand the extent of the damage or the potential extent of the damage. The myocardium receives 5% of cardiac output, and the coronary circulation is blood supply to the heart and the coronary arteries. The arterial blood supply to the heart muscle and electrical system is exclusive. There is no nourishment from the blood within the heart chambers. The heart muscle itself does extract 60 to 70% of the oxygen from the coronary arteries, and this is more than any other tissue. The coronary arteries originate above the leaflets of the aortic valve in the sinus of Valsalva and travel along the outer surface of the heart. Approximately 70% of the coronary artery filling occurs during ventricular diastole. This occurs at a time when the aortic valve is closed and is dependent on the aortic root pressures, which is also considered to be afterload. In order to fill the coronary arteries, the mean arterial pressure, or the MAP, must be greater than 60 millimeters of mercury. That's why ICU patients will primarily be monitored more for their MAP than they will be for their blood pressures because of the drugs that they are on to control their afterload and preload. The coronary arteries can dilate 5 times their size to accommodate the needs of the cardiac tissue. This action is caused by the release of nitric oxide, which causes vasodilation and is also called autoregulation. The O2 demand is affected by the heart rate, preload, afterload, and inotropic activity, which we all know that inotrope is the pumping action. An increase in these factors cause an increase in O2 demand and workload of the heart. A decrease would cause the opposite effect. The right coronary artery, or the RCA, supplies blood to 55% of the SA node, 90% of the AV node. The vascular runs deep into the interventricular septum to supply blood to the node. 90% of the bundle of His, the right atrium and ventricle. 90% of the population are RCA dominant to inferior posterior wall of the left ventricle, the posterior third of the septum, the left inferior posterior fascicles of the bundle branch, and it's also divided into two main branches, the posterior descending and the marginal artery. The left coronary artery supplies blood to the left anterior descending, or the LAD, which supplies blood to the anterior left ventricle, the anterior right ventricle, the posterior right ventricle, the posterior left ventricle, anterior 2/3 of the septum, a portion of the right bundle branch, the left anterior fascicle of the left bundle, and a portion of the left posterior fascicle of the left bundle. The circumflex supplies blood to the lateral left ventricle. 45% goes to the SA node, 10% goes to the AV node, the posterior left ventricle, and the left atrium. The coronary veins will include blood traveling from the left coronary system via the anterior great cardiac vein and the lateral marginal veins. These veins empty into the right atrium via the coronary sinus. The right coronary artery empties directly into the right atrium via smaller cardiac veins. We have many communications between two or more vessels that exist along the various branches of the coronary arteries, which allow collateral circulation. These alternate pathways for blood flow to the heart muscle are helpful if the main coronary arteries become partially blocked. It is usually not sufficient blood supply to muscle survival if it is obstruction of the major vessels. As far as our peripheral circulation, determinants of perfusion or adequate circulation include your cardiac output, which is your stroke volume times your peripheral vascular resistance, blood pressure, which is cardiac output times peripheral vascular resistance, arterial resistance, blood volume, capillary dynamics, and pressure gradient, which is venous capacitance. A little bit more about pressure, flow, and resistance. Blood flow is pressure divided by resistance. Pressure is flow times resistance. Resistance is pressure divided by flow. Atherosclerosis, which is a pathological condition, creates turbulent flow. Turbulence decreases flow at any perfusion pressure, and pulsatility also increases resistance. Larger pressures are required for a given flow rate. As far as cardiac physiology, the primary function is to provide energy to blood to generate or sustain adequate mean arterial pressure, which is required to provide adequate organ perfusion. The contraction of the heart's muscle walls around the closed chambers generates pressure to propel blood through the semilunar valves into the pulmonary arteries and aorta. We have two types of cardiac cells. We have the electrical and the mechanical. The electrical are a part of the conduction system cells. The cardiac muscle is autorhythmic and myogenic, so it's capable of causing contraction without brain control. Action potentials generated at regular intervals cause heart cells to depolarize. We also have the mechanical cells, which are the contractile worker cells. If the electrical system is not working with the mechanical system, that would be called PEA, pulseless electrical activity. And what do we do for PEA? We try to find out what the problem is, give epinephrine, and do a lot of CPR. Our cardiac cells' properties, each cell possesses properties individualistic to their function. If it's an electrical cell property, they will possess automaticity, the ability to spontaneously depolarize without external stimulation through pacemaker cells. The heart still beats when it is taken out of the body and all nerves are severed. This basically means the heart has the ability to initiate an impulse. It also has excitability, the ability to respond to an impulse or stimulus. Conductivity is the ability to transmit an impulse from heart cell to heart cell. Dysrhythmias occur due to increased or decreased automaticity, changes in conductivity, such as reentry, or from an ischemic myocardium. The mechanical working cell properties are excitability, conductivity, and an additional one called contractility. The worker cells are the only ones able to respond to a stimulus with pump action as myofibrils contract. In the polarized state, potassium is intracellular and sodium is extracellular. The inside of the cell is negative to the outside, and this is called the resting state or the ready state. During the depolarized state, the flow of sodium goes into the cell and potassium goes out of the cell. So the discharge state is the contraction. And then as a part of the repolarized state, potassium will return back into the cell and sodium will go out of the cell. This is a recovery phase. This happens each and every time we have a contraction. So as far as the sequence of events that occurs between the end of one heart contraction and the next, we have the electrical cardiac cycle, which is depolarization and repolarization, the mechanical cardiac cycle, which is ventricular systole and ventricular diastole, and then we have the relationship of the electrical to the mechanical events, which is ventricular depolarization triggers systole and ventricular repolarization corresponds to diastole. As far as the electrolytes, the cardiac function is affected by electrolyte imbalances. So sodium again is that major role in depolarizing worker cells, and calcium has a major role in depolarizing pacemaker cells, plus stimulating the myocardial contractility by allowing actin and myosin to bridge. So if we have hypercalcemia, we have myocardial depression. If we have hypocalcemia, it will cause myocardial irritability. Potassium has that major role in repolarization, which increased potassium causes decreased conduction, and decreased potassium causes increased irritability. As far as your cardiac cycle, the cycle is a sequence of events that occurs between the end of one heart contraction and the end of the next. So again, with electrical cardiac cycle, depolarization plus repolarization. Mechanical cardiac cycle is ventricular systole plus ventricular diastole. The relationship to mechanical events is ventricular depolarization triggers systole, and ventricular repolarization corresponds to diastole. This is a depiction of the electrical system of the heart. You can see that the SA node is up in the right atrium. We go through 3 internodal pathways to the AV node. We go down to the junction, bundle of His, left and right bundles, and we end up at the Purkinje fibers. If you notice too that we seem to have more little tiny innervations on the left ventricle because the muscle is so much bigger and stronger and needs more stimulation. As far as the conduction of the cardiac impulse, the SA node is located in the right atrium near the entrance of the superior vena cava. And again, it's that primary pacemaker of the heart in a healthy individual. The inherent pacing rate is 60 to 100 beats per minute with an intact vagal override. The internodal and the interatrial pathways carry impulses from the SA and the AV nodes and conduct impulses across the atrial muscle. There are normally 3 pathways, but conditions do exist in which there are 3 or 6 additional pathways. That would be in a condition such as Wolff-Parkinson-White syndrome or WPW. The atrioventricular node or AV node is located inferiorly in the right atrium, anterior to the opening of the coronary sinus and above the tricuspid valve. Also in this area is the surrounding tissue and the non-branching portion of the bundle of His. This area is called the AV junction. The AV node is responsible for creating a slight delay in conduction before sending the impulse to the ventricles. Inherent rate of the AV node is 40 to 60 beats per minute. So if the SA node would fail, the AV node would take over. It is our second pacemaker of the heart. But because the influence is still coming from above the ventricles, your QRS is going to be narrow, less than 0.12 seconds, as it would if the stimulation came from the SA node. The bundle of His includes bundled fibers extending from the AV node and is located at the top of the intraventricular septum, and this area is considered to be a part of the AV junction. This area facilitates electrical condition between the atria and the ventricles. Inherent rate of the ventricles is less than 40 beats per minute. The bundle branches consist of the right and left division, which conduct impulses rapidly to the Purkinje network. The left bundle branch is anterior and posterior fascicles. Purkinje fibers is a network of fibers extending to all ventricular muscles. It's the end of the electrical system of the heart. The fastest inherent rate becomes the pacemaker of the heart, which is usually the SA node. This is a property of automaticity. I want to talk to you a little bit about irritability versus escape. Very important that you know this. Irritability is when a site becomes irritable and discharges faster than normal. The irritable focus overrides the higher pacemakers. For example, the SA node discharges at 80 beats per minute, but the AV node is discharging at a rate of 90. The AV node then is overriding the SA node and takes control, becoming the pacemaker. This may be a single beat or a total rhythm of irritability. And we want to give the stopper drugs to irritable rhythms, especially if your patient is symptomatic. We also have escape, which is a built-in safety feature to protect the heart in case the normal pacemaker fails or slows below its inherent rate. The site with the highest rate will assume the pacemaker role in the absence of a higher rate. For example, if the SA node discharges at a rate of 40 beats per minute and the AV node discharges at a rate of 60 beats per minute, the AV node will become the pacemaker in the absence of the faster SA node. This is a rescue mechanism to maintain electrical current or a backup. Irritable rhythms are fast, they're early, they're usually decreasing our cardiac output, they're harmful, and so treatment is aimed in eliminating them. So we give stopper drugs, such as antiarrhythmics. Escape rhythms are slow, late, usually maintaining and supporting cardiac output. We want to support them, so treatment is aimed at not eliminating them, but also supporting them. So atropine would be considered to be a starter. Temporary pacemaking, dopamine, isoprel in some conditions. Causes of cardiac arrhythmias are disturbances in automaticity, conductivity, and a combination of altered automaticity and conductivity. EKG paper. We can look at our EKG paper as horizontal as well as vertical. When we are going horizontally, either from left to right or right to left, the boxes are comprised of in time. So if we have small boxes, each small box is worth a 0.04 seconds. Large boxes are 0.20 seconds. There are 5 small boxes in one large box, and you can see that in the paper that's down and to the right on this slide. So we are looking for speed because it's in time. With the vertical lines, it's in millimeters. Each small box is 1 millimeter. 5 small boxes is 1 large box, which is 5 millimeters. And what we are primarily using the vertical lines is when we're looking at the ST segment. Is it depressed? Is it elevated? Because even one little box or 1 millimeter difference can mean that that patient could be suffering from a myocardial infarction, and we need to treat it. P waves represent atrial depolarization, which occurs after the SA node sends out an electrical stimulus. The PR interval is the time that it takes for the electrical stimulus to travel through the atrium, the AV node, and to the ventricle. Normal time is 0.12 to 0.20 seconds. The QRS interval represents the depolarization of the ventricles and normally measures less than 0.12 seconds. And it's very important that you remember all of these intervals because you will be tested on them later on in the semester. The ST segment and T wave represent the early phase of ventricular recovery and then ventricular repolarization. The U wave is a small wave of low voltage, sometimes following the T wave, but the rate must be slow for you to be able to see it. This denotes either depolarization of the Purkinje fibers or hypokalemia. The QT segment begins at the beginning of the Q wave to the end of the T wave. Normally measures 0.36 to 0.40 seconds. Prolongation can be due to drug toxicity and to a list of extensive meds from antibiotics to antidepressants and anti-nausea medications. So this gives you a picture of what we have: an upright P, QRS, and T, and the U wave. Again, the P wave is atrial depolarization. The R wave or QRS is ventricular depolarization. The T wave is ventricular repolarization. And if you think, well, where is the atrial repolarization? It's probably hidden in the QRS. It also shows you in the diagram at the right how we would measure each one of those segments. So if you look for the P wave or the PR interval, we see that that P wave is upright. To the left of the P is that isoelectric line, which is neither negative or positive. Where it leaves the isoelectric line is where we start measuring the PR interval. When it leaves the isoelectric line again for the Q wave is where we would stop measuring for the PR. So if you would be measuring this PR interval, it would be at least a 0.16 seconds because there are at least 4 big boxes and maybe part of another one, so it might even be a 0.18 seconds. The QRS is probably around a 0.06 seconds because it's half of one and the majority of another. And then if we were measuring our QT, again, it's the beginning of the Q to the end of the T. And normal, again, is 0.36 to 0.40 seconds. So those are things that we will be doing at the end, or what we'll be doing in class on Monday when we are experiencing Adobe Connect. Refractory periods. It's important for you to understand this because you will see on your monitor the R on T phenomenon. And so we're going to talk about that so it will make more sense to you. A refractory period, a cell is not yet repolarized and cannot accept and respond to another stimulus, such as a QRS and a T wave, and this is noted on your EKG. If it is the absolute refractory period, this is the time during the cardiac cycle when the cardiac cells are unable to respond to a second stimulus, regardless of the strength of the stimulus. So that is, if you look at the diagram on the bottom right, you'll see it's the beginning of the QRS to the middle of the T wave. That is considered to be the absolute refractory period. In the relative refractory period, it occurs when some of the cardiac cells are capable of responding if the stimulus is strong enough, but the response may be abnormal, which means the R on T phenomenon, the R of a PVC will hit at the peak of the T wave or from the peak to the end of that T wave which is when the myocardium is still vulnerable. So an R on T phenomenon could actually cause the patient or the client to go into VFib or VTAC. So there's ways to determine what the rate is, and it just depends on what is more comfortable for you. We can do a 6-second method, which we can use either for regular or irregular rhythms. And we're going to count the R waves over a 6-second period and multiply times 10 for the rate. If we're using paper with 3-second marks, we just multiply by 20 or count the full 6 seconds. The triplicate method is used for only regular rhythms, and this tends to confuse people, but it's one of my favorites. If you would look at the diagram or the rhythm, you'll see where on the second QRS from the left, where it says A, and there's also an arrow that's pointing down. That is where we would start by knowing we would count over to the next big box, which if the next R wave was at that box, it would be 300. The next big box is 150, the next is 100, the next is 75, the next is 60. So we know this rate is above 70. It may not be an exact, but if you want to use the triplicate, you're going to have to memorize those numbers. But again, you know that it's a sinus rhythm because we can see the P, Q, or ST, and as long as they've got a heart rate, then, as long as they have a pulse, then we know this is a viable rhythm. And we know that it's a sinus because sinus would be between 60 and 100 beats per minute. So you can choose whichever you would like to as far as trying to determine the rate. But don't just go by what the monitor says, because the monitor is just an electrical picture that does not mean that the patient actually has a pulse. So that we would have to compare the rhythm with the perfusion. We also want to see, is this pattern regular? Is the R to R constant? Is the P to P constant? And you need to look at several of those to compare and make sure that they are regular. There are a number of different ways to figure out if they are regular. You can use calipers and just put the tips on the R waves and march them out through the strip. You could use a piece of paper by putting slash marks on that paper where the R waves are and then marching them out through the strip, making sure that they are regular. You can also use a pen by putting the tip of the pen on one R wave and then going backwards to the R wave preceding and put your thumb there, and you can march that through the strip. So there's a number of different ways. You could also use a cardiac ruler, but it just depends on what you have in your pockets of your lab coat. What you also want to think about too is, do they have P waves and do they all look alike? Because if they don't look alike, then that could be showing you that there is another rhythm that's going on inside of the sinus. The PR intervals, are they constant throughout the strip? So that means you can't just measure one and say that's what your PR interval is. You need to monitor at least 3 to 4 complexes of PR intervals. And you need to know, is that within normal limits? Is it between 0.12 and 0.20 seconds? Extremely important when you're trying to determine if the patient is having a block. The QRS complex, do they have a similar appearance, and is it the measurement within normal limits? Is it less than 0.12 seconds or 3 little boxes? Very important that you should know that. So what we can do now is calculate the rates. I don't care which way that you want to use, but we'll take a few seconds and we'll calculate the rates, write it down, and then we'll compare. Okay, let's start with the top left. and we're going to say that that is a full 6-second strip. So our rate would be, if we did the 6-second, it would be 80. If we use the triplicate method, then it would be maybe about 73. But again, it's very similar. If you go to the strip right below that, 6-second method would be 50. If we use the triplicate, it would be about 58. So it's close. And again, it's still a sinus brady. Let's go to the bottom left. And if we did the 6-second, that would be 40. If we did the triplicate, about 37. So it's pretty close. And another thing that you should be concerned on with this one, not only is it a slow rate, but we also have a flipped T wave. It's upside down. If we go to the top right, if we do the 6-second, it's 13, so that would be 130. If we use the triplicate, it's about 140. So again, it's a sinus tach because we see the PQRST. Then if you go to the bottom right, that rate would be about 60. If we did the triplicate, it's a little faster, but so that may not be a total 6-second strip, but you get the idea. And again, we could be measuring the PR intervals, we could measure the QRSs. You note the sinus rhythm if you see that PQRST. Artifact. Some of you may have heard of artifact, and you may think, well, I don't know what that is. So we're going to discuss what it is right now. The top left could be due to old or dry electrodes. So you're not going to get a good picture. You're not going to get a good baseline. That could also be from a phenomenon called 60 cycling, which basically means there's interference electrically, either from the monitor itself, you may not have the right leads on the patient, or in days past, the machines would actually pick up the vibrations from the fluorescent lights that were in the patient's rooms. If you go down to that tracing, that could just be from patients moving around, coughing, taking a super deep breath. So again, that's human interference. If you go to the top right, that again could be dry leads. It could be the patient has a very hairy chest and they weren't shaved, which we're not supposed to. We're supposed to just clip the hair. And then again at the bottom right, that is another example of 60 cycling. So we want to make sure that we can get the best tracing possible. So you're going to either get rid of the excess hair or make sure that you clean the skin. If they have greasy skin, you're going to have to use acetone to take that grease off of their skin, and you may have to actually change your leads more than somebody who doesn't have oily skin or hairy skin. We could also have a wandering baseline, and that would just be from somebody who might be taking deep breaths. And so what we may try to do is just turn them on their sides, do whatever we can to make sure that we get a good tracing, but also to determine that the patient is not symptomatic or having problems. All right, now we're going to get to the fun part. We're going to do normal sinus rhythm, and we're going to do sinus brady and sinus tach. All again, these are the sinus rhythms. And then you also will need to look at your atrial PowerPoint as well, because we'll discuss both of these on Monday in class. So if you look at the bottom right diagram, you see how the SA node will affect both the left atrium and go down to the AV node. The rate is between 60 and 100 beats per minute, and the atrioventricular rates are equal. The rhythm, the R to R, is constant and the rhythm is regular. The P waves are uniform, one P wave in front of every QRS. The QRS complex measures less than 0.12 seconds. And if you look at the bottom, you can see this is an example of a sinus rhythm with an approximate rate of 75 beats per minute. Sinus brady. All of the same criteria for a sinus rhythm, PQRST, but the heart rate is less than 60 beats per minute, resulting from excessive parasympathetic activity, which is from the vagus. The rate is less than 60 beats per minute. The rhythm, the P to P is regular, the R to R is regular, the P waves are normal, each followed by a QRS. The PR interval is normal and measures 0.12 to 0.20 seconds. The QRS is normal and measures less than 0.12 seconds. And again, this is a sinus brady at a rate of 40, and it's probably due to, it could be excessive parasympathetic activity, but it could also be due to an MI. Causes for sinus brady. It could be a highly trained athlete. As a matter of fact, that's how an athlete will find out if they are overtraining, because they'll take their heart rate as soon as they get up in the morning. If it's normally in the high 30s or 40s, and now it's in the 70s or 80s, and they just woke up, then they know that they're overtraining or they're lacking electrolytes. It can also be from patients who are suffering from a myocardial infarction or results of medication, such as digitalis, beta blockers, calcium channel blockers, nitro patches, nitroglycerin, all of those that will be slowing things down. Symptoms are only treated if the cardiac output is low, and that can cause weakness due to inadequate blood flow to the muscles. It could be also due to congestive heart failure or serious ventricular dysrhythmias. As far as treatments, generally treated if there are signs and symptoms that indicate reductions of cardiac output, such as syncope, hypotension, angina, or heart failure. If they have premature ventricular contractions, PVCs, or if the rate is less than 50 and the client is symptomatic. We may treat them with atropine, potentially a temporary pacemaker, dopamine, epinephrine, isoprel if they are a heart transplant. And we could also give them fluids, because if we do give pressures such as dopamine, they also need to have fluids on board. We need to watch them carefully, thoroughly assessing them frequently. Sinus tachycardia. The SA node discharges impulses regularly at a rate faster than 100 beats per minute. This acceleration in the heart rate often reflects overactivity of the sympathetic nervous system or decreased vagal tone and release of catecholamines in response to any form of stress, and this can be found in all age groups. As far as your EKG criteria, the rate is going to be greater than 100 beats per minute. The P to P is going to be regular. The R to R is regular. The P waves are normal, and there's one for every QRS. The PR interval is normal, and it measures 0.12 to 0.20 seconds. The QRS is normal and measures less than 0.12 seconds. And this is an example of a sinus tach. You can see that there is a P wave that's notched on the T wave, and that's due to the fast rhythm. Because if this were a 6-second strip, the rate would be 120. It could also be due to an albuterol treatment. So again, our causes could be excitement, physical exertion, fever, anemia, hyperthyroidism, hypoxia, with the administration of some drugs such as atropine, epinephrine, dopamine, or any other rate-enhancing medications. In these conditions, the risk is usually not great, does not produce other symptoms, and with proper treatment and interventions, the tachycardia will terminate gradually. If the tachycardia is rapid and sustained, it could develop into angina, dyspnea, and heart failure due to the increased workload of the heart and the increased O2 consumption, as well as O2 demand. So our treatment is to identify the underlying cause and treat it. There's always a deducible reason for the tachycardia occurring, which is how we will also differentiate between sinus tach and SVT or PAT, because PAT and SVT are irritability cardiac events, whereas sinus tach is usually telling you that something has happened. Maybe they've been sick and they've lost a lot of fluids and electrolytes, or maybe they're excited. Maybe it's an S2 taking a test, or just really nervous because you're taking boards. So all of these could be caused sinus tach as a natural thing, but as soon as the problem is eliminated, the heart rate will usually go back to normal. Digitalis usually is effective in decreasing sinus tach if we have to use it, but the sinus tach then would have to be due to a left ventricular failure. So that would be more of an illness, but again, there's a reason for it occurring. So now we're going to practice. Unless anybody has any further questions, then we can discuss those as well.